Welcome back to another episode of HealthCap Weekly Wrap.
We've got a lot to cover this week, from schizophrenia care and proper diagnosis to substance use recovery strategies in senior communities.
Plus, we'll dig into some concerns around Medicare's 2 midnight rule, and we'll wrap up with a timely update from the CDC on measles preparedness.
Let's jump in.
We'll start with schizophrenia. It's a brain disorder that affects how a person thinks, feels, and behaves, and it can seriously interfere with daily functioning.
Right? And what's important for us in senior living is that schizophrenia is almost always diagnosed between the ages of 16 and 30. So if an older resident starts showing signs like hallucinations or delusions, it's probably not schizophrenia. It might be something else, like dementia-related psychosis.
Exactly. That's a big distinction. According to the fact sheet published by the Center of Excellence for Behavioral Health in Nursing Facilities, the symptoms of schizophrenia are usually grouped into 3 categories: positive, negative, and cognitive. Positive symptoms include things like hallucinations, delusions, and disorganized thinking. They're called positive because they add something that shouldn't be there, like hearing voices or seeing things that aren't real.
That's right. And negative symptoms take away normal abilities or behaviors. That might include reduced emotional expression, lack of motivation, or minimal speech. A resident may appear withdrawn or disengaged.
Yes, and cognitive symptoms affect mental processes like memory, attention, and problem solving. These can make it hard for someone to focus, follow a conversation, or manage daily tasks.
And here's something people might not realize. Those negative and cognitive symptoms can be just as disruptive as the more obvious ones. A resident who seems emotionally flat or has trouble focusing might be struggling just as much.
Diagnosis really matters. It takes a full evaluation by a qualified professional, and that includes a physical exam, brain imaging like an MRI or CT scan, and a psychiatric assessment. They're looking to rule out things like medication side effects or other medical conditions.
The good news is that with the right treatment, those symptoms can be managed long-term. Most people with schizophrenia can live meaningful, stable lives, but only if they're properly diagnosed and supported.
And that's where it ties back to senior living. If we misinterpret symptoms or jump to conclusions, we might end up using the wrong interventions, or even inappropriate medications.
Exactly. And we know how serious the risks are with antipsychotic drugs in older adults, especially those with dementia. It's not just about getting the diagnosis right, it's about protecting the resident's quality of life.
This is a reminder that behavioral symptoms need thoughtful assessment. Not every hallucination points to schizophrenia, and not every withdrawn resident is just having a bad day.
It's all about looking deeper, asking the right questions, and working as a team.
Another resource from the Center of Excellence for Behavioral Health in Nursing Facilities focuses on validating schizophrenia diagnoses and planning for appropriate care in nursing communities.
It emphasizes that true schizophrenia is rare in older adults. When residents present with symptoms like hallucinations or delusions, it's often due to other causes, such as dementia-related psychosis, medication side effects, or delirium. That makes accurate diagnosis essential.
The guidance recommends a multidisciplinary approach. Diagnosis should involve input from physicians, psychiatric specialists, pharmacists, and the care team. This collaboration helps avoid overdiagnosis and ensures that treatment decisions are grounded in clinical evidence.
One major concern is the inappropriate use of antipsychotic medications. The Center of Excellence stresses that schizophrenia must be clearly documented with supporting evidence, and that antipsychotics should be used only when necessary and with resident-specific justification.
The document also outlines key elements of a person-centered care plan. These include identifying individualized goals involving the resident and their family, and monitoring for side effects or changes in condition.
For communities, the takeaway is clear. Schizophrenia should not be used as a catch-all label for behavioral symptoms. Proper assessment protects residents from unnecessary medications and promotes safer, more effective care.
Another story from the Center of Excellence for Behavioral Health in Nursing Facilities has outlined 4 key ways to promote substance use recovery in nursing communities.
The first is to create a culture of hope. That means shifting the narrative from what someone has done in the past to what's possible for them in the future. Residents living with a substance use history should be seen as individuals with potential not defined by their diagnosis.
Second, care should be person-centered and strengths-based. Recovery looks different for everyone, and care plans need to reflect that. Instead of focusing only on deficits, teams are encouraged to build on each resident's interests, goals, and existing skills.
Third, the guide emphasizes empowering residents with meaningful choices. Whether it's participating in support groups, helping shape their daily schedule, or contributing to community decisions, giving residents agency is essential to recovery.
The fourth point is collaboration. Recovery is supported best when teams work together. Nursing, social services, mental health professionals, and peer supporters all play a role. The guide highlights how interprofessional teamwork can reduce stigma and improve care outcomes.
These recommendations are especially relevant for senior living communities where residents with substance use disorders may face added stigma due to age or medical complexity.
By embracing recovery-oriented practices, communities can create more inclusive environments and offer residents the dignity, respect, and support they need to thrive.
Let's shift to diabetes care and talk about insulin technique based on a new article published in Mayo Clinic Proceedings. It shares global expert recommendations from the Fitter Forward initiative, where 16 specialists across 13 countries reviewed advances in insulin delivery and education.
First, it emphasizes selecting the right injection devices. Proper needle length, pen design, and handling can reduce pain and improve insulin absorption, crucial for maintaining consistent glycemic control.
Next, it outlines step-by-step injection procedures, from preparing the insulin and priming the device to injecting at a 90-degree angle and holding it in place for about 10 seconds. Best practices designed to ensure full dose delivery.
Third, it tackles lipodystrophy prevention, recommending regular rotation of injection sites and consistent monitoring to avoid lipohypertrophy, which can interfere with insulin effectiveness.
Finally, the article underscores structured training programs. It calls for personalized education, routine technique assessments, and ongoing reinforcement to empower both residents and caregivers.
For senior living communities, these Fitter Forward recommendations are a big opportunity. By training staff, residents, and families on proper insulin injection, communities can reduce complications, improve glucose outcomes, and enhance resident comfort and confidence.
Okay, next up. A report from the Office of Inspector General takes a critical look at Medicare's two-midnight hospital policy and how it impacts care delivery, including transitions to senior living communities.
The two-midnight rule was introduced by CMS to clarify when hospital stays should be billed as inpatient versus outpatient. If a physician expects the patient to require hospital care that crosses at least 2 midnights, the stay qualifies as inpatient.
However, the OIG found ongoing vulnerabilities in how the rule is applied. Some hospitals are misclassifying short stays, leading to either overpayments or denied claims. This confusion can directly affect residents who are being discharged to senior living communities.
One of the major concerns is that short inpatient stays may not meet the criteria for Medicare-covered skilled nursing care, even if the resident clearly needs follow-up support. That can leave residents and families facing unexpected out-of-pocket costs or delays in care transitions.
The report also points out that CMS's oversight systems aren't consistently catching these errors. Hospitals may not receive adequate feedback on whether their billing practices align with the policy, which perpetuates the problem.
For senior living professionals, the takeaway is that discharge documentation and admission timing can significantly affect a resident's coverage and care path. Working closely with hospitals and understanding the implications of the two-midnight rule can help protect residents from gaps in service or financial strain.
That last story really highlights how federal policy can impact care on the ground. And it's not just Medicare rules. Public health guidance plays a big role too.
The CDC has released an updated measles preparedness toolkit designed to help healthcare providers, including senior living communities, respond effectively to potential outbreaks.
The toolkit includes checklists, fact sheets, communication templates, and educational materials for staff, residents, and families. It's meant to support planning, prevention, and response in environments where the risk of exposure could have serious consequences.
Measles is highly contagious and especially dangerous for adults over 20, pregnant individuals, and people with compromised immune systems. The CDC notes that even one case can trigger a significant public health response.
The toolkit outlines key steps for communities, starting with ensuring staff and resident immunity. It provides guidance on vaccination protocols, including when adults should receive MMR doses or have immunity confirmed through testing.
It also offers templates for outbreak communication, screening tools for visitors and new admissions, and protocols for isolation if someone shows symptoms.
According to the CDC, there have been over 1,200 confirmed cases across 37 states this year, with several active outbreaks still ongoing. For senior living communities, the stakes are especially high given the vulnerability of the population.
Implementing the CDC's guidance can help communities stay ahead of an outbreak, protect residents, and reassure families that comprehensive precautions are in place.
And that wraps up this week's episode of HealthCap Weekly Wrap.
We covered a lot, from understanding schizophrenia and ensuring accurate diagnoses, to building recovery-oriented environments for residents with substance use histories.
We also looked at the ongoing challenges tied to Medicare's 2-midnight rule and finished with a practical rundown of the CDC's new measles preparedness toolkit.
Thanks for tuning in.
For more details on any of the stories we talked about today, be sure to check out the weekly roundup on Angie's blog at healthcapusa.com/Angie's blog.